Good evening, everyone. We're here for today's ninth basic module of critical care medicine with the topic Fast Hugs PID by Dr. Akash Das. Something about Akash, I want to tell he's a diligent clinical pharmacist having a passion for critical care pharmacotherapy, patient care, and medication safety. After graduating from the Tamil Nadu Dr. MGR University, he got experience as a clinical pharmacist in a major trauma and surgical intensive care unit, followed by multi-speciality critical care unit. As a part of the multidisciplinary team in the ICU, Akash has focused on assessing the patient's pharmacotherapy needs at the bedside, promoting antibacterial stewardship, reducing medication errors, and educating the team members about the recent advances in evidence-based medicine. And today's topic is so much relevant in a critical care practice. Seeing a ICU patient is so much different from any other patient, and hence a different set of criterias of assessing a patient, which will help not only the physicians but also the upcoming pharmacists in evaluating the medication management of these patients. So without further ado, I'll ask Akash to present further and give more insights on this topic.
Thanks, Abde. Thanks a lot for the introduction. Good evening, everyone. Today's topic is Fast 6 BID. It is a very crucial and a very useful tool at bedside for everybody who is working in a critical care unit for their daily assessment of the patients. So let us start this with. So next slide. So my name of my presentation is FastX BID. So I don't have any relevant financial relationship or any commercial interest for this. So what are we going to learn in this presentation? So about the standardized care options for the critically ill patients, elements of FastX BID and their importance, learning therapeutic options for feeding, analgesia, sedation, thromboprophylaxis, VAP prevention, stress ulcer prophylaxis, glycemic control, spontaneous breathing trials, bowel cares, prevention of catheter-related or Rhine-related infections, de-escalation of antibiotics, and the pharmacist perspective of the elements in the team during the ICU rounds as a multidisciplinary team. So these are the things that we are going to learn in this topic today. So first of all, what is FastDrugs BID? This thing stands for feeding, analgesia, S for sedation, 3 for thromboprophylaxis, H for head-up position, U for ulcer prophylaxis, G for glycemic control, S for the spontaneous breathing trial, B for bowel care, I for the indwelling catheter removal, and D for the de-escalation of antibiotics. So these are the elements of FastDrugs BID. So who invented this mnemonic FastX BID? So back in 2005, Jane Lois Vincent popularized the FastX mnemonic for recalling the issues to review when looking after a critically ill patient. So this was subsequently updated to FastX BID by Vincent and Hatton in 2009, and now it is used in most of the critical care units across worldwide. So first of all, the first element, that is feeding. Why is feeding very important? So why is feeding important in any critically ill patients? Because critically ill patients, their illness exists in like three phases: the early, the late, and the post-acute phases. So first, we'll always talk about the acute phase. In acute phase, what happens is your body is in a state of catabolism. So what happens is your body is breaking down uh, proteins or the calories faster than it can absorb. So that is what is called as hypercatabolism. Okay. So this time what happens is during the time of critical care illness, your body will lose the muscle, which will lead to sarcopenia. Because of inadequate nutrition, the patient can go into multi-organ failure. So this is why feeding is important in any critical ill patient. So when should nutrition therapy be started and which route should it be preferred? So there are two worldwide societies which lead nutrition. One is the American Society of Parental and Enteral Nutrition, that is ASPEN, and the European Society for Clinical Nutrition and Metabolism, that is the ESPEN. So what do these two societies they recommend? So what are the routes of feeding? First we see. First thing, if your patients are conscious and oriented, oral route is the best preferred route for these patients for nutrition. Second is the enteral route. So for patients who are not able to take orally, or if they are taking orally but you're not, that it is inadequate, or if the patients are mechanically ventilated, so for these patients it is the enteral route. So an enteral route can be due to a esophageal tube or esophagostomy, gastrostomy, gyrostomy tube, or transpyloric feeding tubes. These are the routes by which enteral feeding can be provided. And the third is the parenteral route. Patients in which oral as well as enteral routes are not accessible, like any patients with any GI abnormalities or patients who have gone any small bowel resection, in which you cannot immediately start enteral feeding. So in those cases, if it is more than 5 to 7 days without any nutrition, both Aspen as well as Aspen tell that you can go for parenteral route. So this is what ESPEN tells. Like, so 0 hours oral diet shall be preferred over enteral nutrition, parenteral nutrition, in critically ill patients who are able to eat. Till 48 hours, if oral intake is not possible, then critically ill patients should be started on enteral nutrition or early parenteral nutrition. And if it is 72 hours or 3 to 7 days in which you have even not started enteral feeding, parenteral nutrition should be started in those cases. So, how much calories or energy does a patient require? The society ESPEN tells that 25 to 30 kilocalories per kg per body weight is the target that you want to achieve in critically ill patients. So, for obese patients, if BMI is 30 to 50, it is 11 to 14 kilocalories of the adjusted body weight per day. And if it is more than 50, it is 20 to 25 calories of the ideal body weight per day. So we have to calculate the adjusted body weight as well as the ideal body weight. So next, how much of proteins is usually recommended? Because proteins are a very important part of the diet. So in that, Aspen recommends that 1.2 to 2 gram per kilogram per day, and Aspen also recommends 1.3 to 1.5 gram per kilogram per day. So that is so. Your protein requirement should be 1.2 to 2. It should not exceed more than that. As I've already told, in acute phases, body is in a state of hypercatabolism. So you should always not overfeed the patient. So proteins should not be more than 2.5 grams per kg per day, as it causes azotemia, hypertonic dehydration, hyperammonemia, and also metabolic acidosis in the patients. So then, where to restrict proteins? As I have told, sepsis and septic shock in the initial phase, you should definitely restrict the proteins. AKI or CKD patients, you should restrict your proteins a bit. Patients with refractory status epilepticus, you should restrict your proteins. Chronic malnourished patients who have a risk of refeeding syndrome, you should always restrict your proteins as well your calories. So, how to check that the feeds are absorbed properly in enteral feeding? So there is something called as the gastric residual volume. So what is the gastric residual volume? So gastric residual volume is the amount aspirated from the stomach following administration of the enteral feed. So how much of gastric volume is amount to be safer? So this is like an aspirate when you aspirate through the NG tube, an aspirated amount of less than 500 ml every sixth hourly is safe and indicates here that your GI tract is functioning safely. Intolerance of enteral feeding is defined when more than 500 ml of aspirate is there. So every sixth hourly, when you get more than 500 ml of aspirate, then you can think of actually that your enteral feeds are not being absorbed properly. So while most patients will tolerate enteral nutrition via gastric tube, why this happens is some patients will experience delayed gastric emptying and raised gastric residual volumes as a result of sedation, pain medications, hypothermia, decreased movement, and effect of being critically ill. So GRV measurement is one of the most common practices in ICU nutrition therapy, but there is very little evidence for its efficacy, but it's very widely used. What are the causes of intolerance of feed in critically ill patients? Like I have told, mechanical ventilation, long-term immobilization, bowel care, disease conditions like sepsis, septic shock, or any obstructive shock, use of opioid-based sedation, especially electrolyte abnormalities like potassium, phosphorus play an important role, and also refeeding syndrome in chronic malnourished patients. So, what to do if the GRV is more than 500 ml? So, what will you do at that point of time? So, what we can do is you can decrease your feeding rate and observe. Prokinetic agents can be used to improve the gastric emptying and feed tolerance. Target bowel movements if patients have not passed his balls and the abdominal are distended. Check for trace elements like magnesium and phosphorus in chronic malnourished patients. And one of the most common things is that sometimes Riles tube is out of position. So always try to recheck the Riles tube position for the patients. So what then we have talked about refeeding syndrome. So what is refeeding syndrome? So this process occurs when the body has been in a state of starvation or malnourishment for some time and feeding is restored via any route for the patient. So why is it important? It's like some geriatric age group of people who are not, so in Indian scenario it is very important because usually geriatric patients they don't have a very good intake normally. And especially patients who are having any GI issues, SMA syndrome, or patients who are uncontrolled diabetics, patients who are alcoholics, and patients who have chronic pancreatitis or oncology patients post chemotherapy, these patients are always at a risk of developing refeeding syndrome because their body will not be used to the feed. Like when you suddenly start the feed at a very high rate, or when you give a lot of calories for that patient. So this results in symptoms like arrhythmias, myalgia, rhabdomyolysis, feed intolerance, and increased risk of infections and liver failure also. So in these patients, always keep a watch and initiate feeding slowly and progressively. So prokinetic agents, what prokinetic agents can we use in critically ill patients? A very common one is metoclopramide. So the dose is 10 mg every 8th hourly. Caution should be there in patients who have QTC prolongation, renal impairment, and extrapyramidal syndromes. And then also erythromycin is again erythromycin because of the motilin receptor, it binds and it also increases the gastric emptying rate. So that erythromycin can also be used. So the dose is every 250 mg every 12 to 8 hourly. Watch for loose stools. Levosulfide can be used. So the dose is 25 mg every 8 hourly. Tremors and rigidity are very common side effects for this drug. So those note this point as clinical pharmacist. Every time you start a prokinetic, use it judicially. GRV should be monitored that it has reduced or not over the next 24 to 48 hours. And it has started reducing, you should always taper the prokinetics and stop as they have the side effects of their own. So next is parenteral nutrition. So we have seen that enteral nutrition is the best feasible route whenever the patient is not able to take orally. Now, if you're not able to start enteral nutrition also, parenteral nutrition has to be started for the patient. So it refers to the provision of calories, amino acids, electrolytes, vitamins, minerals, trace elements, and fluids via parenteral route. As told earlier, indicated for patients in whom enteral feeding is not feasible for more than 72 hours. It can be used for patients to achieve calories and nutritional requirements where enteral feeding was not enough to meet the requirements. Even if enteral feeding, if you are giving and you are not able to reach the calories, you can supplement it with parenteral nutrition. So, indications for TPN: chronic intestinal obstruction like the GI malignancy, high flow GI fistulas, congenital GI malformations like the SMA syndrome, postoperative patients with or without anastomosis having a leak, severe diarrhea or feed intolerance, prolonged NPO status for more than 72 hours. These are the indications in which you can start about think about starting TPN for a critically ill patient. So what are the axes? One is the central, one is the peripheral. So central line and peripheral line both you can use to give parenteral nutrition for the patient. So next, central versus peripheral nutrition. Okay, so what is central and what are the differences? So central TPN, if we see, it is easy to meet the nutrition needs. I'm sorry. There is no limits on the osmolarity. little risk of thrombophlebitis. You can use it for a long term, may require general anesthesia, greater risk of causing infections, increased cost, greater risk of mechanical injury, air embolism, and venous obstructions. Okay, so what does peripheral T pain offer you? Unable to meet the needs for calcium and phosphorus. Maximum rate of calcium gluconate that can be given is 200 mg per kg per day. Maximum dextrose is 12.5 percentage. Peripheral TPNs are suitable only for short-term use, not for long-term use. Less risk of catheter-related infections because it is given through a peripheral vein, but it can always cause a thrombophlebitis for the patient. Lower in cost, but the cost difference is not a very huge between central as well as peripheral TPN. There is less risk of mechanical injury, air embolism, and venous obstructions. So this I have compared actually 1,000 ml of central TPN as well as the 1,000 ml of peripheral TPN. So these are the differences. You can see central TPN always has a more osmolality, peripheral TPN has a low osmolality. Calories, so every 1,000 ml of central TPN has 1,022 calories and peripheral has only 763 calories. So the proteins are 40 grams and this is 30 grams. Dextrose is 120 grams. This is 80 grams. So these are the basic differences between central and peripheral TPN. So what to monitor as a clinical pharmacist when the patient is on a parenteral nutrition? So infusion related reactions like fever, chills, etc. Check for micronutrients like magnesium, calcium, phosphorus when especially on peripheral TPN. Blood sugar fluctuations. Patients develop hyperglycemia because it contains dextrose, especially diabetic patients, and existing sugar levels might rise. Triglyceride levels because it has a lot of lipid containing emulsion in it. So you should always check your triglyceride levels at least once 5 to 7 days whenever your patient is on long term TPN. Okay, so these are the things that you can monitor. And also a thing that whenever your patient is on central TPN, always assure that a dedicated lumen is given for the central TPN. That only TPN goes through that line, nothing else goes because this will reduce the risk of infections in your patient. Okay, so complications of TPN, like I have told. So pneumothorax in central and it can be pneumothorax, arrhythmias, thrombosis, air embolism, and catheter-related sepsis if it is not maintained properly. And feeding regime related hyperglycemia, excess weight gain, or fluid overload, patient can go into pulmonary edema. Cholestasis because of the content, micronutrient deficiency, zinc, manganese, serum electrolyte abnormalities, refeeding syndrome, and hypercapnia of overfeeding. These are the complications of TPN. So this was about feeding. So mostly I have told you about two societies in Europe and America. This in India also, our experts from Critical Care Society have developed this practice guidelines for nutrition in clinically ill patients, and it's specially based on the Indian scenario. So we all can go through this because this will help you to decide the nutrition practice in an Indian scenario. So next is analgesia. So next part. So I will just cover it a little because we'll see it in detail when next presentation for FCPI comes up in pain, delirium, agitation. So analgesia is a very important topic in which pharmacists can play a very vital role in selection of agents for patients and regulating the dose and duration of analgesics for the critically ill patients. So pain can play a major role in patients as inadequate analgesia may lead to major problems like hemodynamic instability, intubation in chest injury patients, intolerance in ventilated patients, agitations, etc. Assessment of pain by a validated pain assessment scale is important if patients are conscious and oriented. So there are various pain scales which are validated internationally. Please use those to validate what is the level of pain that your patient is having. It becomes challenging when patients are unable to validate their pain, especially geriatric age group. And in ICU, use of regular OPD analgesics like NSAIDs are not appropriate as patients have various physiological and metabolic dysfunctions like platelet dysfunction, cardiac disorders, renal impairment, etc. So, what analgesia can we choose? So, first thing is acetaminophen or paracetamol. So it is the safest mild to moderate analgesic in critically ill patients. So dose of, when you give it as an analgesia, paracetamol is given every sixth hourly, 1 gram every sixth hourly. As we all know, 4 grams is the maximum dose. So to provide adequate analgesic effect for a paracetamol. So make sure as a pharmacist that at least 6 hours of gap is maintained between the doses. Staggered doses can lead to toxicity. Monitor LFTs in between and use in caution with CLD patients as a pharmacist. Opioids. Next thing. So opioids are the cornerstone for analgesia in the ICU. Given their efficacy, their abuse is also very common. So be very careful while using opioids. So first thing is tramadol can be used in ICU patients as it is as it is a mu receptor antagonist and may be helpful for mild to moderate pain patients who are conscious, especially patients who have post-operative pain, patients who have undergone orthopedic surgeries, patients who are conscious and oriented, patients trauma cases. These type of cases, tramadol is a good analgesic. So dose is 50 to 100 mg every 8 hourly to 6 hours. So you can give it maximum of 300 mg per day. So common side effects are nausea, vomiting, and paralytic ileus. So in tramadol, be very careful because it is the administration route which actually makes the vomiting or the nausea effect for tramadol in patients. And then it is lidocaine patches there. Lidocaine patch can be used in conscious patients as an epidural pump or a local regional blocks. Available as transdermal patches also for over 12 hours. So main disadvantage is the narrow therapeutic index. Therefore, cardiac toxicity can also occur if the doses are not monitored properly. Okay, so these transdermal patches can also be used for patients who are not in very excruciating pain. Next thing, fentanyl. Widely used analgesic in critically ill patients worldwide. Easy of administration and titration of doses make fentanyl a very good agent for analgesia in ICU patients. It can be used as a IV bolus. It can be used as a continuous infusion also. So dose for bolus is 1 to 2 mites per kilogram. For infusions, it is 1 to 2 mites per kilogram per hour. And maximum you can give is 10 mites per kilogram per hour. So fentanyl is available as a transdermal patch also. So you can use it for patients who are in palliative care, like for palliative care and for chronic pain patients, you can use fentanyl patch. It is metabolized in the liver, it is highly lipid soluble, and so because of that, it accumulates in the liver impairment patients. So you use it with caution. Side effects: drowsiness, respiratory depression, and paralytic ileus are the most common side effects of fentanyl. Due to the long context sensitivity half-time, active metabolites, fentanyl has now been replaced by newer alternatives in the Western setup, especially. So, olfentanyl and remifentanil are two drugs which are the newer synthetic opioid analgesics used for analgesia in critically ill patients worldwide in the West. Advantages are there are no active drug metabolites, no accumulation in liver failure, short context sensitivity, so quick onset and offset of action is there for olfentanyl and remifentanil. Disadvantage is that it is very expensive and it is not very widely or feasibly available in India for its use. So again, morphine. Morphine is a longer acting analgesic than fentanyl. It can also be given as an IV bolus or an IV infusion. So dose, if you can see, it is 1.1 to zero point 0.2 mg per kg as an IV bolus, or you can give it 0.05 to zero point 0.1 mg per kg per hour as an infusion if you are giving for patients. Like it can be used for patients who are in very severe pain or who have developed tolerance to fentanyl. So you can use as an alternative in this. Disadvantage: active metabolites accumulate in case of renal and hepatic impairment, and the clearance is reduced. So patients take more time to come off from morphine. So for chronic patients, enteral route can be preferred, but oral bioavailability is very poor and therefore may require more frequent dosing. Okay. So next is sedation. So analgesia and sedation. So first we see the analgesia, now it is sedation. It goes hand in hand because most of our ICU patients, they will be mechanically ventilated, or even if they are not ventilated, even if you are using an IV mask also, they can be agitated sometimes. So what you can do is you can always use sedation for those patients because any agitation can lead to ventilator dyspnea, increase oxygen consumption. Patients can self-remove their tubes and invasive lines and catheters and Ryle's tube also. So because of that, sedation is very important. Sedation has to be monitored properly as a wrong or excessive amount of sedation can cause problems of their own, including low GCS, withdrawal, etc. So as a pharmacist, always keep an eye on how much of sedation is going, how many days it is going, what type of sedation is going on, how quickly can we wean off from this sedation. So how much of sedation is the right amount of sedation? So there are various scales. So one such scale which is used worldwide is Richmond Agitation and Sedation Scale. This is the RAS scale. So this gives you what is the sedation score for this patient. So when you give sedatives to your patient, you want their RAS score to be just about here. So alert and calm, drowsy but they are awakening to the voice, light sedation. So this is exactly where you want your sedation amount to be, so that your patient is just about sedated and does not fight the ventilator or does not remove the lines, etc. So what type of sedation can be used in ICU? Benzodiazepines are very commonly used in ICU, like midazolam and lorazepam, for long-term ICU sedation and deep sedation, especially for head injury patients, polytrauma cases. Midazolam is very good. Midazolam can be used as a continuous infusion. Boluses also can be given. It can also be actually combined with fentanyl into a single syringe itself. Lorazepam can be used for boluses in non-ventilated patients for controlling the outburst agitations. Use in caution with patients having hepatic and renal failure, very important, as midazolam, as we all know, that the active metabolizers is metabolized in the liver, so be very careful. And in renal failure also, its half-life is very prolonged, so patients may take time to wean off when there is renal failure. So propofol, most widely used drug in ICU because of its pharmacokinetics. As a CP, it's we should always know propofol's pharmacokinetics. It is very easy to titrate. It has very good volume of distribution. It has very good onset of action, very quick and very good wean off properties, because it has a very high. It is a very high lipid soluble drug, so it tissue distribution is very good, and its context sensitivity half-life is also very low. So because of that, it gets weaned off also very properly. So useful in patients requiring short-term ventilation or weaning off from ventilator, like post-operative cases. Side effects are like, since it's an emulsion, has an increased risk of infection. So you have to always keep an eye on this, and can cause increased triglycerides and lactic acidosis and propofol infusion syndrome at very high doses, especially in pediatric patients. Intermittent boluses are usually avoided as it can cause profound hypotension when given in boluses. Doses 1 to 3 mg per kg per hour as an ICU sedative. This is dexmedetomidine. It is increasingly used nowadays in the ICU for short-term sedation in patients who require mild sedation, weaning off from the ventilator, patients who are on NIV mask but a little bit of agitated, patients developing delirium in the ICU. Dexmedetomidine is a very good drug. It is used as a continuous IV infusion, has quick onset and is titratable. Side effects include transient bradycardia and hypotension. So as a CP, always have a look. Whenever your patient is on Dexmed, patients will develop sinus bradycardia. Always have a look. Studies for 72 hours more than of Dexmed has been not very conclusive. So it can be used for short-term sedation. So for less than 72 hours for patients. Dose is 0.5 to 1.5 mites per kg per hour. That is dexmedetomidine. Another thing is that it is expensive also, so use it wisely. Next thing is clonidine. So clonidine, as we all know, it is an alpha agonist. So clonidine at right doses can provide anxiolysis, sedation, analgesia, and ICU, and can be used to decrease the dose of the other agents. Like if your patient's BP is high and you are using Dexmed, still it is not being continued. You need uh, something to control the BP, as well as you need a sedation also. In those cases, clonidine is a good drug. So it is a dose-based sedation, is titratable, can be monitorable easily using the clonidine infusion protocol. There are various infusion protocols internationally available for the clonidine infusion. Can be converted to an oral drug which has excellent bioavailability also. As a CP, we can always think of this. In renal impairment patients, the clearance is decreased, therefore low doses may be required. So dose is 100 to 150 mites bolus. Please be very careful. Don't push it very fast. Administration of clonidine is very important. Otherwise, your patient might crash. An IV infusion, it is 0.2 to 4 mites per kg per hour is the dose. So side effects include hypotension. That is why definitely don't give boluses while the patient is on an infusion, and diuresis. This is about clonidine. This is NAJM's paper in which they had shared about the various sedative and analgesics which are commonly used in ICU. We can all go have a look. It's very good, given in detail. So this is just a glance for all the sedatives that are used. So next is ketamine. Ketamine can actually also, it is an analgesic. It can be used in critically ill patients as an adjunct sedative to taper off requirements of longer acting sedatives and to decrease the ICU stay. So these things is the ketamines usage in ICU. Can be used for short-term procedure in ICU patients like line placements, for intubation, and for dressing of wounds actually. So because these are painful, patients might get agitated. So always ketamine can be given prior to them. Can be used as a continuous infusion also in patients. Advantages are negative opioid receptor and NSAID side effects are not observed with the ketamine infusion. Dose is 1 to 2 mg per kg as bolus, and IV infusion 0.5 to 1 mg per kg per minute. So this is about ketamine. So this was about sedation. Next is thromboprophylaxis. Why is thromboprophylaxis required in ICU patients? So VT can manifest as a deep vein thrombosis on pulmonary embolism. So risk factors includes venous status, vascular injury, and hypercoagulable disorders. A majority of ICU patients carry at least one risk factor for VT. All our patients, at least one additional risk factor will be there to have a cumulative effect. Venus, although these risk groups can be easily identified, it is impossible to predict which patients will experience a thromboembolic event. So, therefore, in your ICU, whenever a patient comes, always do a VTE risk assessment and add your DVT prophylaxis accordingly. Okay. So there are various risk factor assessment scales for DVT. One such assessment tool is the Caprini risk assessment tool, in which you can easily calculate based on these factors. And anywhere, if your score is like 5 in your ICU patients, you can definitely think about starting DVT prophylaxis for your patients. Okay. So always do DVT risk assessment whenever your patients come into ICU. What is the type of DVT prophylaxis? So one is non-pharmacological. So in this, whenever your patients cannot be put on pharmacological DVT prophylaxis, always non-pharmacological DVT prophylaxis can be put for patient. Example, if patient is having a disseminated coagulopathy, liver disorders with increased INR, recent head injury, or immediate post-op patients with hemorrhage, thrombocytopenia, found to be inferior to pharmacological DVT prophylaxis. Therefore, either it can be used in combination with pharmacological DVT agents or should be, and as soon as you get the chance, you should switch over to pharmacological therapy as soon as possible. These devices include compression stockings and devices and pneumatic DVT compression pumps. So this is uh, about non-pharmacological DVT prophylaxis. Okay. So next, if I may say, it is pharmacological prophylaxis. What we can always keep a watch on. So first thing is heparin. Unfractioned heparin. It can be used in patients in which recent head injury patients or anything in which you are a bit reluctant to start directly on low molecular weight heparin. So always unfractioned heparin can be given. Can be given 5,000 units subcutaneously every 8 to 12 hourly for the prophylaxis. Advantage is that it can be used in patients with renal impairment in ICU. Disadvantages, heparin-induced thrombocytopenia, keep a watch, elevated SGPT levels. Next is enoxaparin, very widely used low molecular weight heparin. So it comes in pre-filled syringes of 40 mg, 60 mg, and 80 mg. So it is preferred because it is an ease of administration. It is an OD, it's a once a dose administration. Be careful as a CP in patients who have renal impairment and creatinine clearance less than 30 ml per minute, and the dose is 0.1 to 1 mg per kg per day subcutaneously. Next thing is dalteparin. Dalteparin can also be used. So dose is 5,000 units subcutaneous every day. Avoid in renal impairment patients. Next is fondaparinux. This is also available in pre-filled syringes. Useful for patients who are having a history of heparin-induced thrombocytopenia or in patients with borderline thrombocytopenia. You can always go with fondaparinux. Dose is 2.5 to 5 mg subcutaneous daily. Avoid in patients with renal failure. Okay. So these are the this is the comparison. So like what are the advantages and disadvantages of unfractioned heparin as well as low molecular weight heparin, as you can see. So a low molecular weight heparins, it has a longer duration of action when compared to unfractioned heparin. Lab monitoring of anticoagulation is generally not necessary with low molecular weight heparins. So whenever this is there, always you can start the patients directly on low molecular heparin for patients in ICU. So points to remember, SSEP, review DVT prophylaxis for all patients admitted in ICU. At least STDs should be placed in patients in whom pharmacological DVT prophylaxis is contraindicated. Pharmacological prophylaxis should be started as soon as possible once the contraindication is relatively lower. LNWHs are the first choice in patients for prophylaxis until and unless renal impairment is there. Monitor renal functions. If patients are in severe shock, where sub-Q absorption is a concern, heparin can also be given intravenously for DVT prophylaxis. Okay, so you can always think of this. So next is head of the bed elevation. So studies have shown that elevation of the head 30 to 45-degree angle can reduce the incidence of gastroesophageal reflux and especially nosocomial pneumonia in patients who are mechanically ventilated. So it is a part of the ventilator associated pneumonia prevention bundle, the VAP bundle in all the ICUs, and it has to be followed. Patients who are nursed to 45-degree angle have been shown to have a decrease in aspirates, and also patients have like whenever this is done, they have always have a less risk for developing ventilator associated pneumonia. Also helpful in patients receiving CPAP or an IV trials. Be careful in patients with spine injuries and abdominal injuries. So always have a look of abdominal elevations. Okay. So next is pharmacological option. So next is stress ulcer prophylaxis. So what is stress ulcer prophylaxis? Okay. So now stress ulcers can develop in critically ill patients because their body is always in a state of stress. Okay. So this stress, it has been there are two risk factors which is associated with stress related mucosal injury. So one is respiratory failure requiring mechanical ventilation for at least 48 hours, and coagulopathy also, in which it is defined platelet counts less than 50,000 or an INR more than 1.5, or APTT which is more than 2 times the normal APTT value. Okay. Other risk factors include head injury with GCS less than 10, thermal injury, facial hepectomy, hepatic or renal transplantation, multiple trauma with an injury severity score of more than 16, spinal cord injury, hepatic failure, history of gastric ulceration or bleeding in the previous year, medication used like corticosteroids or NSAIDs and vasopressors, and hypotension. So these are the indications in which stress ulcer prophylaxis are indicated in a critically ill patient. Okay. So pharmacological options, what do we have for stress ulcer prophylaxis if we see? One is pantoprazole, okay, 40 mg either orally or IV every 24 hours is good enough for stress ulcer prophylaxis. Ranitidine 150 mg PO or 50 mg IV every 6 to 8 hours. This is the dose for ranitidine if you want to give for, so 150 mg BD for tablet. If you're giving IV, 50 mg, 8 tali to 6 tali is dose for ranitidine. Same for lansoprazole in pediatric cases, 15 mg to 30 mg every 24 hours is the case for pediatric patients. Now, if you ask which is superior, pantoprazole or ranitidine, no pharmacological agent has been proved better than the other in stress ulcer prophylaxis head to head. Okay, so you can use either pantoprazole or ranitidine. So next is glycemic control. So why is glycemic control important in critically ill patients if we want to see? So hyperglycemia in critically ill patients, as we all know, it's bad. It has been documented in various good papers that hyperglycemia can increase morbidity and mortality as well as increase healthcare cost. It can increase the complications in patients, like it can retard the wound healing. There is always an increased risk of infections whenever there is poor glycemic control. GI motility is impaired. In head injury patients, it can increase the edema and result in more secondary brain injury. So it can induce polyneuropathy, and so because of this, glycemic control in critically ill patients is very very important. Okay. So what in studies we have seen is that Hyperglycemia is bad. Hypoglycemia is also bad. One thing which is bad is also that the variability in glycemic control. I mean, in the sense, your patient's one value is 66 and next value is 300. And the next value is again 120. Next value is again more than 250. So this variability is also not good for critically ill patients. So glycemic control should be appropriate. So what is the recommended blood glucose levels in critically ill patients? So it is 140 to 180, as we have seen in the earlier topics also. The 140 is 180 is not recommended as the recommended blood glucose in clinically ill patients. So state of hyperglycemia, always keep a note as a pharmacist. Case state of hyperglycemia in critically ill patients can occur in non-diabetic patients also, because stress response is there, infection especially, if your patient is on steroids, medications diluted in dextrose, especially antibiotics, these all can induce hyperglycemia in patient who is not a diabetic also. It is recommended to closely monitor glucose level in such cases and treat them if they are persistently high. HbA1c, it has not been a very good investigation of choice for glycemic management in critically ill patients, because if your sugars are persistently high, regardless of the HbA1c, you have to treat it. An oral hypoglycemic agent should be avoided in critically ill patients, as they can cause hypoglycemic episodes when the body is in a state of stress, aspiration is there, feeding status is not very adequate. So always avoid OHS in your ICU. So next question is, how will you control the glucose if you can't give OHS, right? So what are the current recommendations? Worldwide, insulin therapy is the best way of glycemic control for ICU patients. Insulin is the best therapy. Subcutaneous and ICU and IV insulin both are used in ICU patients worldwide, but subcutaneous insulin is not preferred in patients because it is given in boluses, which can be erratic, which can lead to sudden hypoglycemia, and it is not titratable also. So always, whenever you start with IV insulin in your patients. Okay. So uh, what is the best way of glycemic control? So what we have seen, how to prepare the IV insulin infusion. So it's very simple. You take Actrapid, which is your regular human insulin. You take 50 units of Actrapid and you dilute it with 49 ml of NS, and you start the infusion. Okay, so here is an example of variable rate intravenous infusion. So in this you can see if what is the glucose, so how much ml per hour of Actrapid or how much unit per hour of Actrapid you can give, or insulin you can give to your patient. Okay, so next thing. So how to minimize this insulin requirement? So this is not given in any guidelines, but various ICUs across the world, what they have do is, you want to wean your patients off from insulin infusions or from subcutaneous insulin. So in those cases, you can always use basal insulin. So NPH, that is Insulatard, and Lantus can be used in such patients as a basal insulin for patients after 48 hours. So when your patient is requiring insulin after 48 hours, also persistently the requirement is high, you can start using basal insulin to cut down these. So be very careful while giving IV insulin for your patient, because whenever you give IV insulin, it is always preferable to check sugars every hourly or at least every second hourly for the patients. Okay, because risk of hypoglycemia is very higher in IV insulin, and especially non-feeding hours or patients when they are on NPOs. Okay, so monitor potassium levels, because insulin will deplete your potassium levels and replace the potassium adequately. Never stop IV infusions for your insulin abruptly. Keep, as a clinical pharmacist, please see this in your ICU, that the nurses don't stop this abruptly. Educate them that you should always taper and stop IV infusions, or you should always give a basal dose or a subcu dose before than that, because you will get a rebound hyperglycemia, which is very bad. Okay. So next are spontaneous breathing trials. Okay. These are the trials which are used in mechanically ventilated patients to wean them off from ventilators. Okay. So these trials are important because they lead to the discharge of the patients from the ICU. Okay. Basically, this is what you see. This, if you see your patient in your ICU, if you see in the picture below, CPAP or pressure support, this is what is weaning trials. Okay. Or in small machines which are called as BiPAP. So these are all spontaneous breathing trials that you're given to your patients for them to get weaned off from ventilators. Okay. So as soon as possible, we should, as a multidisciplinary team, you should suggest. So what a pharmacist can suggest for spontaneous breathing trials. If your doctor is having a chest X-ray in his hand, it is getting clear, and clinical scenario is okay to wean, the pharmacist can always ask the physician about the weaning as it will cut down the sedation days. Very, very important. If required, the sedation, if your patient is on fentanyl infusion, okay, and midazolam infusion, and if you are trying to wean the patients, as a job your pharmacist that, then always switch them to dexmet sedation or clonidine for such patients. So failure of weaning can due to be a lot of factors, including infection also or any mechanical problems. If weaning is going on well and somebody asks for an ET culture and it grows for an organism, not necessarily ET might be the source. Be very, so as a pharmacist, you can always look for this. You can always suggest to look for other sources. So whenever you're weaning, if you're sent for an ET culture and it is growing something, but your patient is weaning well, you don't need to treat it. Might be just be a colonizer. So you can look for the other sources. So SBTs are always a multidisciplinary decision, and you can always find your role in it, as I have mentioned, as a pharmacist. Next is ball care. Okay, ball care is an important setup in ICU because most of the patients are bedridden and they develop ileus very fast, either due to disease conditions like trauma, malignancy, electrolyte abnormalities, or used of opioid-based sedatives. Okay, be very careful. More than 72 hours of not passing stools is considered to be constipation in ICU patients. So this should be a concern because it can lead to abdominal distension, which will lead to slow weaning from the ventilator, increased intra-abdominal pressure, and always an increased risk of infections as well as feed intolerance. So these, because of this, bowel care is very important. So how to deal with constipation? Use sedatives. Like I always told, use sedatives, especially opioid sedatives, for the least duration as possible. Ensure that feeding has been initiated in your patients. Ensure adequate hydration. Use of prophylactic laxatives like Crimafin, Dufalac can be used in your ICU. If balls are still not moved despite of the laxative, digital evacuation with the use of suppository and enema can always be suggested from the pharmacist side. Okay. Next thing is diarrhea. So your patient might pass stools, but at some point of time, what happens is it can lead to diarrhea. It can be due to many things. So you, as a pharmacist, you can keep a watch. Can be due to hypercaloric feeding. It can be due to antibiotics usage, especially antibiotic associated diarrhea is very common, and prokinetic agents, and then overuse of laxative. Because of this, diarrhea can also be a concern. Why diarrhea is a concern? Because it will lead to abdominal infection, like gut translocation can be there, because of which it can be a problem. And also it can induce skin rashes or bed sores, and it can worsen them whenever there is diarrhea. Okay, so because of that, you should always be careful about diarrhea also. So always use stool charts for assessing and evaluating diarrhea. Example, the Bristol tools stool chart is there. So reassess feeding and ongoing medications and see if there anything can be changed. Like if your patient is on prokinetics and your patient is developing too much of loose stools, hold the prokinetics. If your patient is on too much laxative, hold the laxatives. Addition of fiber in feed helps, so is adjusting the calories and the protein content also in some cases. Use of probiotic agents and loperamide can always be used for treating diarrhea if it's not controlled. Never stop feeding even though if diarrhea persists. Even though somebody suggests that we'll hold the feeding, never stop the feeding. You can decrease the calories, but you can never stop the feeding for the patients. Okay. So next thing is indwelling catheters. So most of your ICU patients, because they are critically ill, they will require central lines, they'll require dialysis catheters, they'll require PICC line, and they'll also require an arterial line during their ICU stay. So while these lines are important for their ICU stay, these can also give rise to multiple infections. So that can be a source of catheter related or central line related or associated bloodstream infections. Okay, because certain times what will happen, the nurse might use it and the nurse might not switch off it, or it might not close the valve, or what will it happen is they will use a medication, especially like propofol or TPN, They might not flush the line and they might just keep it like that. That will be a good breeding ground for the bacteria. Okay. So because of this, what can a pharmacist ensure? Invasive lines are managed and used in a sterile way. As a part of the multidisciplinary team, you should always tell the nurses dressings are changed on time. You can see after administration of medications, lines should always be flushed. Always educate your nurses in the same way. If patient develops fever spikes, you should always keep a watch on the duration of the line, okay? And it should be always prompted to your physicians. Conversion of IV to oral drugs gradually whenever possible. As a pharmacist, you should always do to minimize the use of central lines, okay? If line is not required and patient is being transferred to the ward, removal of invasive lines by securing a peripheral line can always be suggested. Okay. So always as a pharmacist, you can play a role in this also. Next thing, antibiotics de-escalation. Okay. So as we all know, as CPs, as clinical pharmacists, antimicrobial stewardship is the need of the hour, and it is an important responsibility of the clinical pharmacist. So antibiotics, especially broad spectrum antibiotics and higher end antibiotics, are used in ICU because your patients are critically ill, like septic shock. Your patient can always prefer with septic shock, or your patients might be exposed to previous broad spectrum antibiotics. In those cases, you will use antibiotics like polymyxin B or fosfomycin in your patients. Once initiated, antibiotics should always be reviewed on a regular basis on everyday plan so as to prevent the prolonged use of broad spectrum antimicrobials. Saying this, one side, this is there, one side, you should always see for the clinical scenario of the patient also. As a clinical pharmacist, you should always see that your patient has clinically responded or not, which is very important. Okay. And then you should always take a call on de-escalation. You should always keep the culture reports wherever the culture reports have been sent. Always see if the culture reports have been updated, if the sensitivity has been updated. Always update this to your team, to your physicians, and de-escalate antimicrobials whenever possible. Okay. So, role of the clinical pharmacist: daily review of the drug chart for antibiotics and clinical assessment of the patient that your patient has responded to the antibiotics or not. Follow up of culture reports and conveying the same to the physicians about the sensitivity patterns. Prompting for de-escalation if the culture reports have come at 48 hours, at fifth day, or at 7th day. Choosing an appropriate antibiotic if de-escalation is amended, and deciding for the dose frequency. And also you can convert from IV to oral whenever possible. Patients, if patient is transferred out of ICU and culture reports are pending, proper handover to the clinical pharmacist in the ward for follow-up of the reports, and ensuring de-escalation if required should always be prompted by the ICU clinical pharmacist. Okay. So this is what my hospital's FastHug BID looks like. Okay. So as you can see, this is done by the doctors, this is done by the nurses, this is done by the pharmacist also. As you can see, everybody plays a role in FastHug's BID. So it is done in each shift. So you can see what the feeding that the patient is getting, what analgesia is the patient getting, sedation, what sedation it is getting, any contraindication is there or not, DVD prophylaxis, head of the bed elevation, SUDs like stress ulcer, prophylaxis, glycemic control. Have you assessed for weaning, the bowel movements, indwelling catheters, and de-escalation? Okay, so this is about FastX BID. In your ICUs also, you can do the same. So we'll go for a case scenario. A 52-year-old male patient, a known case of diabetic and hypertension, on irregular medication was admitted in the ICU post-op following an intracranial hemorrhage with midline shift, for which he underwent decompressive craniotomy. What would be the FastX BID plan for him? What will you decide as a pharmacist? Okay. So what we'll discuss it one by one later. So I'll just tell you the questions. You can just keep your answers in mind. What would be the feeding plan for this patient after 24 hours if the patient's GCS is not improved and he is not been extubated? Okay. So first is TPN, second is post pyloric feeding, third is enteral feeding. Okay. Keep your answers in your mind. Next, what sedation and analgesia would you choose for this patient post-op with a GCS of 5 NT? So pentamidas, dexmedetomidine, ketamine, or propofol. What will you choose? Okay. So, what thromboprophylaxis would you choose for your patient? Heparin, enoxaparin, stocking compression devices. Okay. So, choose your answers. Head end elevation of your patient would be 60 degrees, B 90 degrees, or C 45 degrees. What do you think? Should be the head of the bend elevation. Okay. And post-op patient, your patient has hyperglycemia. What would your glycemic control plan be? So it will be A, metformin, or will you choose an insulin infusion, or would you choose sulfonylureas like glimepiride? Okay. So, as we told, feeding. So, this patient might be intubated and ventilated for a couple of days because of the intracranial hemorrhage. And because of that, RICE tube should be placed and enteral feeding should be initiated within 24 hours to 48 hours for this patient. Okay. So, this is the answer is enteral feeding. No parenteral nutrition, no post pylori feeding. Go with enteral feeding for the patient. Analgesia, appropriate analgesia and sedation is to be given for this patient. So you can choose fentanyl and propofol, or you can use fentanyl or midazolam combination also for this patient, so which is good. Never directly start on dexmed. So next, thromboprophylaxis. So what do you think? Heparin. So the correct answer would be, because your patient is ICH and immediate post-op, there is always a risk of rebleeding. So in those cases, you cannot choose a pharmacological DVT prophylaxis. You should choose compression stocking device for him. Okay. And you should continue this until your patient's scan is stable. And once the scan is stable, you can always discuss in your with the neurosurgeon and with your team physicians, and then you can start the pharmacological DVT prophylaxis. Then head and elevation, as we have already told, 30 to 45 degrees of head and elevation should be there for your patient. That is the right answer. Ulcer prophylaxis, okay. Post-op ventilated patient, therefore your patient should deserve a PPI or an H2 receptor antagonist should be there in the drug chart, okay. Then sugars and glycemic control. If your patient is on irregular medication and he is a known diabetic, and if the patient is more than 180, like your glucose levels are more than 180 to 200, always start insulin persistently if it is high, because a good glucose control will lead to favorable post-operative outcomes, as well as also it will also decrease the risk of developing infections, and it will also reduce the rebound edema also. So once the feed is initiated, watch for bowel movements, as patient will be sedated with opioids, can develop ileus. So always laxative can be added on the second day if the stools have not been passed. So those were the answers for the multiple choice questions which were done in the case scenario. Now I have some other MCQs for you also. Okay, so a patient in your intensive care unit is receiving sedation as a past tux. Which medication is commonly used for sedation in this setting? A. Aspirin, B. Midazolam, C. Acetaminophen, or D. Metoprolol. So quite easy as we have discussed. So answer is B. Midazolam. Okay, so midazolam is the right answer. So next, in FASTEC's acronym, why is thromboembolism prophylaxis particularly important for patients who are immobilized? Okay, A, to prevent allergic reactions, or B, to prevent risk of blood clots, to improve muscle strength, or to enhance cognitive function. Okay, which one is it? Okay, so as we all know, so answer is B, to reduce the risk of blood clots. Okay, next, what role does head of the bend elevation play in preventing complications according to the PASTEX principles? So, A, reducing the risk of ventilator associated pneumonia, improving visual acuity, enhancing gastrointestinal motility, or minimizing skin breakdown. So, as we have already told, 30 to 45 degrees of head end elevation is always reducing the risk of BAP. Okay. So, next, for a patient in FASTEX care, which factor is crucial for effective glucose control? Maintaining high glucose levels, high blood sugar levels, administering insulin as and when required if it is persistently high, monitoring blood pressure, or encouraging excessive carbohydrate intake, which is good for your patient. So the right answer is administering insulin as required for glucose control if the blood sugars are persistently high more than 180. Next thing, in context of analgesia, in fast drugs, what is potential drawback of over reliance on opioids for pain management or for sedation in critically ill patients? Okay, so what is the potential drawback if you rely a lot of opioids? A, is it improved wound healing, risk of respiratory depression, or is it enhanced immune function, or is it increased alertness? Okay, so what is it? So what do you think? So the answer is a risk of respiratory depression. Always be careful, especially in geriatric age groups. They will develop CO2 narcotics. They will require intubation most of the times. Okay. So for next MCQ, for head of the bend elevation in fast drugs, what degree of elevation is commonly recommended to prevent aspiration in mechanically ventilated patients? What do you think? 30 to 45 degrees, A, B 60 to 75 degrees, C 90 degrees, or D 120 degrees? Which is it? So it is 30 to 45 degrees. A. A is the right answer. Okay, 30 to 45 degrees of head elevation is recommended. Next thing, for assessing sedation in fast drugs, what scale is commonly used in ICU patients? Okay, as we have discussed. So CAM ICU scale A, B visual analog scale, C Wong Baker Pace's pain rating scale, or D the RAS scale. Which is it? So as we have already discussed on the topic of sedation, RAS scale, Richmond Agitation and Sedation Scale is the right answer for this. Okay. So the last question, how does ulcer prophylaxis contribute to preventing stress ulcers in critically ill patients within the FASTEX framework? How does it? So A, by promoting acid reflux, or is it B, by suppressing gastric acid secretion, C, by encouraging spicy food intake, or D, by increasing the caffeine consumption? How does ulcer prophylaxis work? Very easy. Again, by suppressing the gastric acid secretions. Okay. So these so we have gone through FastTrack's BIDs, all the elements. We have gone through the this thing also. So what is the take home message for this topic? So as a pharmacist, as any healthcare professional working in the ICU, when you always go in, give your patient at least one fast hug a day. This was said by the person who invented fast hugs. Okay, so give your patient at least one fast hugs a day. So when you give fast hugs, you at least cover so many things as a clinical pharmacist, which is actually important for your patient. Okay, at one go. So this is very important. So try to give your patient at least one fast hugs a day. And then again, why only fast hugs? So maiden mnemonic is another mnemonic which will also help a clinical pharmacist to ensure that daily routine for patient has been completed. So what does maiden stand for? I'll just tell you. M for medication reconciliation, a bread and butter for you, because every day the pharmacist should go through whenever a new patient comes, whatever the patient was the patient on previously. If it's a new patient, if the patient has been transferred in from the ward, what were the medications that the patient was getting in the ward? Very important. A for antimicrobials, as I've already told, whatever your patient is on, what is the indication? You should always keep these things in mind. I, indication for the medications, daily drug chart review, daily drug utilization review, seeing that does your patient require that medication which is on the drug chart today. D, drug dosing. Again, very important. Is the dose correct according to the renal failure or according to the hepatic impairment? Is the dose correct? E, electrolytes, hematology and labs. Is your drug is what is the electrolyte abnormality which is there? Is anything to be corrected in those things? Because of the drugs, is anything happening? This has to be seen by the clinical pharmacist. N, no drug interactions, allergies, duplication, and adverse effects. Go through your drug chart every day and correlate with your patient and see if there are potential drug interactions or not. If there are drug interactions, see if what is it causing clinically to your patient, which is very important. Not only theoretically, you should assess it clinically in your patient also, and you should then tell it to your consultant. See if any drug allergies are there during the history taking. Drug duplications are there or not. Many of the time it is missed, always play an important role. Drug adverse effects. Any if you are giving any medication which is there on drug chart, and if you are seeing any adverse effect out of it, always be careful. S, stop dates. Stop dates for antibiotics, even stop date for steroids. What is the indication? Why is the steroid being given? When should it be tapered and stopped? Always write review date or stop dates for such cases. Okay. So these are my references which I have used to prepare these presentations. Okay. And thank you. I'm thanking FCPI for providing me with this opportunity for taking this presentation. I hope this will be useful for all the students or for all the people who want to join ICU as a critical care pharmacist, because this is something which you can always start with. This is the basics. And if you have any questions, you can always reach to us at this given email, and follow FCPI for such updates. And thank you. Thanks a lot. Over to Abde.
Yes, Akash, it was a wonderful presentation, and you gave such a clue towards how a clinical pharmacist can be confident in his practice and able to cover most of the things that one needs to look for in an ICU patient. I know we have always been told about the maidens part. We always see drug interaction, allergies, reconciliation. But when it comes to an ICU patient, what one needs to know is the fast hug is also important, along with the maidens combination. So I would like to ask you, Akash, like how has it been beneficial? What all interventions it has allowed you to do, and how is the acceptance rate when you show them through this fast hug BID in your ICU or in your
Yeah,
practice?
they. It has been a very good response actually, because um, if I'm talking about feeding, I can help on my consultants, or I can help in my team with the dietitian to see that what feed is going, what type of feed is going. If any aspirates are there, I see and I go through it. If any prokinetics is added or not. Whenever prokinetics are added, I am always careful to see that if the patient is developing any side effects because of those drugs, and how quickly I can taper it off. That is very important. If the feeds are being absorbed well and good, I usually about 48 hours we start tapering the prokinetics. It plays a very important part. Analgesia again, whenever so sometimes your patient's BP might be high just post-op or a trauma case. Somebody might suggest that you start a young patient, maybe you many of the times they'll tell that you start a patient on antihypertensive, but the source will be either pain or tube intolerance. Okay, so analgesia is very important. So that is one thing. Another thing is that whenever it is opioid based analgesics, always patients have been started weaning, try to come off. Try to come off of the opioid based sedatives. It has been always been helpful. The more fast we do this, it is beneficial for the patients. So cut off the sedation days, which is very important. Then again, glycemic control. Glycemic control in my ICU, it is the clinical pharmacist who takes a very important call, because we see how many times frequently the glucose is being monitored, how many times the patient has required insulin, and what I have done to reduce the variability or to reduce the insulin requirement for my patient. So this is very important. I educate the nurses, especially the same in glycemic control. Antibiotic de-escalation. Anytime an antibiotic is started on a broad spectrum, I always put the review date. First review date will be 48 hours after the culture reports have come. If we are continuing it, the second review will be at fifth day, and then it will be at the seventh day. So always put review dates, always prompt in the plan, always see what IV to oral drugs you can always connect. There might be a fever. You might not know the source. There is an indwelling catheter. It is day 7 of the catheter. The patient is receiving IV medication. As a clinical pharmacist, always try to slowly convert all your IV medication, if the feeds are absorbed properly, to oral medications. So for me, prophylaxis, DVT prophylaxis, many of the times it gets missed. So continuous stressing. So patient is on, at least the patient should be on stocking compression devices. If not, if no contraindication, start the patient directly on DVT prophylaxis. Hold the DVT prophylaxis whenever a surgery is there. Pharmacist plays an important role. Always anticipate. See if any surgery is planned, hold the DVT prophylaxis. After the procedure has been done, how fast we can restart it is also very important. That also we have to prompt. So a clinical pharmacist always plays an important role. Spontaneous breathing trials, somebody has sent an ET culture, it has grown Acinetobacter, your patient is bleeding, you want to extubate your patient. Your Acinetobacter might not be the source at all. So, as a pharmacist, you can always suggest this and you can always come off of an antibiotic. So, as a clinical pharmacist in my ICU, as I said, I give a fast hug to my patient every day, and I suggest it should be taken up by all the people working up in the ICU, so that it is very easy to do. It is anybody can do. A nurse can do. A doctor can do. A clinical pharmacist can also do fast hugs. So my ICU, the acceptance has been very good, and it has actually improved me also to see the important aspects for your patient at one go. So it has been like that.
Yeah, absolutely true. I mean, in rounds also, it is so helpful at times where you can, just cross-check all the things, and
Yeah.
it is so simple, so easy. Just you have to know the background of it and what is right, what
Yeah.
is wrong. Uh,
Yeah.
and just thinking about feeding, it's such a huge topic on its own. There have been so many
Yeah.
debates and so many things.
Yeah.
But do you think we should consider this as a drug, and should clinical pharmacists have a more say in calculating the feeding, or no, or will it just be a more of a burden?
I'll say that as a ICU clinical pharmacist, I personally I am very much interested in nutrition. And it should be a pharmacist's role also, because if you see in every, even in board certified critical care pharmacist regime, or the this thing, if we see the syllabus, if we see, nutrition is a part of it. Nutrition is a very important part of it. So you should know the basics at least of nutrition, if not in depth of the detail, because as you told, it is an ocean of its own. So, but at least you should know the basics of nutrition. That at least your patient is get the feeding or not. When your ICU has a feeding protocol, pharmacists can always check whether it has been followed or not, whether the feed has been correctly increased or not. In patients who are chronically malnourished, are we giving too much of feeding or not? So, if the patient is not getting any feeding, have we started TPN or not? If we have started TPN, have we come off from the TPN or not? So, as a pharmacist in nutrition, also, if I'm telling, if not in depth, but always keep a watch on nutrition. It is very important for your patient, because at last, nutrition is something because of which your patients will not go into critical illness polyneuropathy, and the stay in ICU will be less, and you can send your patients out of the ICU also very quickly. So nutrition is a very important role. That is why I've always told, always there is a very good chapter which has been written in clinical nutrition by our Indian experts. I request everybody to go through it. It's very good. It's very easy. It's very easy to understand also.
True, Akash. I think so. You have given us such a wonderful presentation today, and I'm sure the ones viewing will have it ease while they are going to their ICU for practicing and using this tool, such an important tool. So thank you, Akash, once again, and goodbye.
Bye, Abde. Thank you. Thanks a lot. Thanking FCPI also for this opportunity.
Yeah, yeah. Thank you, Akash. Bye. Goodbye.
Bye.